Hello, welcome to another episode of the Podiatry Detectives with my friend and colleague who's dressed quite casually today. Looking very slick as always, but still quite casual. How are you, Mr. Colombo? Mr. Tausif, how are you?
I'm not too bad. How about you?
I'm well, alhamdulillah, I'm well. It's all good. Today, we are going to be speaking about a topic that both of us are very passionate about because we both see a lot of athletes with leg pain. And we're going to go through this in quite a lot of detail. This might not be as long as some of our previous episodes, but we'll see how we get on. Before we start, Mr. Tausif, let's ask you a uncomfortable question. So all your millions of adoring podiatry patients that love you and fans that you have all around the world can learn a bit more about you. So describe to me what your perfect room would be. What would you have in a room if you could have any room and you were going to be stuck in that room for a considerable amount of time? What would you like in that room?
Right. That's a very difficult question, actually.
Well, if it was easy, I wouldn't be asking you, would I, mate? That's fine.
I think, of course, you'll need a bed, my laptop. I'd like our holy book in there, and that's pretty much it.
Okay, cool.
I think that would cover pretty much everything.
Good. I would like a fridge and a coffee machine as well, and a microwave. Everything else I agree with. Okay, let's start this.
I would like a little bell in my room so that I can basically turn and get something.
Okay, so don't you dare say Shin Splints. Right, this is the title of this talk, because if there is a word that me and Tausif dislike with a passion, it is Shin Splints. My passion for exercise-induced leg pain has come from Dr. Nat Padia, who is teacher and mentor, who also hates the term Shin Splints. Now, exercise-induced leg pain, what is it? Exercise-induced leg pain is exactly what it says on the tin. It is leg pain that is induced by exercise. We don't use the term Shin Splints anymore. You can get it with any sport. I frequently see it with runners, but I've seen it with footballers. What about you, Tausif? What kind of sportsmen?
Runners is one of the main ones which actually trickled through to the clinic. I had a fast bowler, footballer. Yeah.
Oh, you had a international fast bowler, didn't you, from Pakistan? Yeah, I remember that. That was a really interesting case.
Really interesting case.
Yeah, in fact, I might just like remind me to talk about him a bit later, because what you did with his a run up and how you change the actual width of his stride was awesome. It was brilliant, and I learned so much from you, how you managed him. Now I'm going to talk about a lot of different types of exercise-induced leg pain. There's quite a few different ones here. The medial tibial stress syndrome, which is what most people refer to as Shin Splints. That's primarily what I'm going to talk about regarding the rehab process. However, we are also going to touch upon a few other conditions like chronic exertional compartment syndrome, stress fractures, different types of nerve entrapment syndromes, popliteal artery entrapment syndromes, and radiculopathy. Now, I've put 3 dots after that because I haven't put a slide there for it, but I'm going to briefly talk about it now. Radiculopathy is when you have a impingement on your sciatic nerve in your spine, and that leads to exercise-induced leg pain in your calf muscle, or it's usually the calf muscle. But it can happen at the front of the leg, depending on what branch of the nerve is entrapped. But it usually happens in the calf. So let's go through the first case study. This would be generally a very active, probably hyperactive person, maybe a marathon runner, or maybe they're doing endurance sports. I've had an Ironman runner with this. Ultra marathon runners, they complain of leg pain, which is relieved by resting. Just a couple of minutes, it's gone. Now, when you examine them, there's nothing that you can find in clinic. This is all based on history, okay? They will talk about a very large area and on their legs, and it's almost always both legs. And it's usually the front of the leg. This is chronic exertional compartment syndrome, and it is very difficult to pick up, and it is often misdiagnosed as shin splints. This is treated differently. There is a way to test this. It's quite invasive. They put needles within your leg, and they make you run with a pressure gauge attached to you, which checks your pressure in your different compartments. And they make you run on the treadmill, and they see if that pressure is going up considerably. Usually people need a surgical solution to this. Do you have any comments on this particular slide? No? Okay, then the next one. The next one is, I've seen this a few times. It is also very competitive, very usually quite in their 20s and 30s. They're complaining of pain, usually on the outside of their leg, but they get specific symptoms of pins and needles, paresthesia. They can sometimes feel tightness. It's also relieved by just resting for a few minutes, and it's usually the one leg, and it's usually at the front of the leg, on the outside of the leg. Now, this can be superficial perineal nerve entrapment syndrome, which is a mouthful, but it's quite easily diagnosed, actually. If you can give some local anesthetic into the superficial perineal nerve, just a little bit, and make them do a little run around the block, and if they don't have any pain, then you know that it is that. This is also relieved. The treatment for this is quite simple. We just need to take some of the inflammation and pain away from the impingement that's happening on superficial perineal nerve. The main thing here is there'll be specific symptoms of pins and needles and numbness and paresthesia and tightness in the foot and the leg.
Yep.
Any comments, Tausif? No?
Yeah,
let's move on. This is quite rare. Now, I have not seen this, but I know some of my colleagues have seen this. You'll get a lot of pain in one or both of your calves, and you can relieve this by resting. And it'll be a strange feeling that you'll be running around. You'll get this tightness, tenderness in your calf muscle, and you cannot run anymore. The pain is quite severe. You rest for a couple of minutes, and then you can go again. Now, you can see by the actual scan that sometimes the popliteal artery can get entrapped. This is popliteal artery entrapment syndrome. Okay, there are 5 different types of popliteal artery entrapment syndrome, and it gets quite complicated. But this is not one of the most common causes of calf pain. The most common cause of calf pain that me and Tausif would see all the time in clinic is a calf strain. That could be either the gastrocnemius, which is the 2 muscles at the top of the calf, or the deeper muscle, which is the SOLEUS. Now, you can strain it, or you may tear it. If you come to me and Tausif, we would do an ultrasound scan, and it gets picked up I've picked them up quite well. Yeah. We see calf strains quite a bit, don't we, Tausif?
Absolutely, especially in the active athletes.
How do they normally present?
Well, usually, yeah, you can actually have a sudden sort of onset, as well as it can be like over the period of time, and then suddenly they've done something and which has actually sprained or strained the calf. But yeah, that's
So usually, sometimes they may say they've been shot in the leg because it's an initial and they can't carry on. I had before the lockdown, I had a 800-meter runner who strained his like SOLEUS, which is the deeper one, which was quite difficult to rehab actually, very, very difficult to rehab. The calf strains you will see a lot. Tennis players get this a lot, mainly because they are suddenly starting and then they go off again. I mean, like you play like badminton, don't you? So that is one of the things in badminton where you've got that sharp movements, as with tennis as well. With running, it tends to be accumulative rather than a sharp movement. But we do see a lot of calf strain. This one, okay. This will be, normally these are the conditions, they can't put their finger on where it hurts. Normally here, they'll point to you where it hurts. And it'll be specific. They might get night pain. They'll be walking with a limp. And they might even be able to tell you this was the time where I got affected. It's usually only one leg is affected. Now, this is a stress fracture. Happens a lot.
Yeah.
One of the tests that me and Tausif do, and we get them to hop on the spot. So if we get you to hop on the spot on a leg and you can't do it, that sends some alarm bells ringing in our heads. And this can be managed by offloading and resting. I sometimes send off for an MRI scan to find out how bad it is.
Yeah.
Sometimes I might put them in a boot. We might be looking at supplements. We might be looking at just changing the amount of activity and the load.
In certain ages and at certain, like if there are female, I'd probably be looking at whether they have got any conditions like osteoporosis. Vitamin D deficiency is another one which I tend to look out for.
Absolutely. With females, I'm going to talk about females a bit later, but there is a scan called a DEXA bone scan that you can scan the entire body and it tells you about bone density. So there's a reason why some females may have lower bone density. There is a like crescendo kind of pain, so the pain really builds up. It's not a dull ache kind of pain. The next one is the one that we are going to focus on, which is what we see the most common. These are also very active athletes. Pain can be in one or both legs. Recently, I had a whole spate I had a couple of rugby players, I had a hockey player, both with medial tibial stress syndrome, which is what this is, which is what people refer to as shin splints, but in both legs. And the area was a lot more bigger than what you can see in the picture. It was a lot more diffused, which set some alarm bells ringing, but it was medial tibial stress syndrome. And I knew that after the MRI. Now, the pain lasts, unlike the other things, the other conditions that we spoke about. When you finish running, the next day you are in pain, and this can last for hours, can last for days, to the point where you're struggling to walk. It's usually the lower third of the inside of your leg, and there's a variety of different reasons why you can get it, but it's usually because you've changed the intensity and the duration of your exercise, but obviously shoes and the type of surface that you're running in, and even the way you run, which is what we're going to speak about a bit later, can have a massive impact on you developing this condition or not. Medial tibial stress syndrome, Tausif, is what we see as sports podiatrists a hell of a lot. Yep. Would you agree? Yeah.
Definitely. I think out of all the leg conditions that you've actually mentioned, medial tibial stress syndrome is one of the most common ones.
That is right. Yeah. So What is it? Okay, so the way we class it, if I send a patient off for an MRI, I ask the radiographer to class it using the Fredrickson classification system. Now, this is very technical and I could go into this in detail. I'm going to keep this plain so that everybody can understand. But essentially, can you see grade 0 to grade 4B? Now, most people will have a grade 2, okay? When that means there are some changes inside the bone. If you start going to grade 3 and grade 4, that means there are changes, intercortical signal changes. If it's a grade 4B, that's actually a stress fracture. So what that goes to show is it's not you've got medial tibial stress syndrome or you haven't. There is a continuum. The way you would manage the way you would manage a grade 1 to the way you would manage a grade 3 would be completely different. We know from the evidence it is a overuse sports injury in athletic population is 4 to 19%, 4 to 35% in the military population. This was something done by Winters et al. In 2018. Mm-hmm. I know from speaking to a physiotherapist who took care of the Cyprus army actually, and he did a study on it. They see a lot of it in Cyprus, and he used shockwave, which I'm going to talk about that a bit later. Runners can get this, footballers. It's being classed by Laura et al. In 2018 as one of the most common musculoskeletal conditions. Okay. We spoke about gender. Obviously, we're going to speak about that in a minute. Females can be more likely to get it for a few reasons. There's also, they might have less muscle bulk around the calf. Now, muscle dissipates shock. So that can be one of the reasons. Training errors, getting ready for that marathon, which I don't think anybody's running this year or next year now, until we have a vaccine, but getting ready for a marathon. Imagine, you know, Tausif, the amount of people that were getting ready for the London Marathon that are not going to be able to run it now. Or isn't it finished? Yeah?
Yeah, April. It was in April, but it's not going to happen. And I can't see many. I've got a few patients who've actually booked some runs in October, November time. But I don't think they'll be happening.
This is not going to happen. This is an unprecedented situation in our world. Surfaces, yes. So obviously, if somebody is used to running on a softer surface and then starts doing pavement running and starts ramping it up, then that could be a reason. Moving from a shock-absorbing running shoe to a less shock-absorbing running shoe can also be one of the underlying factors that may be contributing to you getting medial tibial stress syndrome. Have I missed anything else?
Well, generally looking at the foot positioning, like navicular drop and drift, has got some evidence with regards to the risk factor.
Absolutely. Let my phone ring is fine. It's
in simple terms, we would say that flat feet.
Flat feet, yeah. Well, although that being said, how many Afro-Caribbeans have flat feet? A lot of them. I actually don't see many Afro-Caribbeans with medial tibial stress syndrome, which is, I mean, I couldn't tell you if ethnicity played a role in it.
Well, I find that it's one of the risk factor. It's not the risk factor. It's coupled with all the other things. I do see pes planus sort of foot type associated with the medial tibial stress syndrome more than the pes cavus foot type.
Okay, cool. So we talked about gender. Now, women have an increased risk to incur stress fractures. This is the female triad, which we have spoken about before, but this is a red S. Now, the red S is what is currently used in evidence-based medicine to explain why females are more likely to incur bone stress reaction injuries rather than stress fractures. So as you can see, there are various factors at play apart from the menstrual cycle. There's endocrine, metabolic, growth and development, massive psychological thing. Maybe they're doing too much for different reason. There's like gastrointestinal issues as well, hematological. I'm not going to go into detail about all of these because this would be a very boring talk on its own, and it would be a very long talk, and I'm sure everybody will fall asleep, including Colombo over there. So, but I just wanted to point out that there are specific risk factors that are around females that can make them more susceptible to getting a bone stress reaction.
Definitely.
So, rehabilitation. Now, what do we know about the evidence? The evidence says graded exposure program, Winters et al. 2018. Then somebody else said stretching and strengthening eccentric calf exercises. That was done by Dugan in 2007. I like this one. This was a paper by Deely in 2003, where he said strengthening core hip muscles, core stability, working on abdominal muscles, which is what you did with your patient, and proper receptor training can help for a neuromuscular education to help treat medial tibial stress syndrome. But a graded loaded exposure program is essentially what we need to do, and we need to look at that curve and manage. I have to say to patients, we need to calm stuff down, and then like I have to like build stuff up. So initially we just try and calm it down. So we're looking at taking away some of the load, some of the running of playing football or rugby or hockey, and then slowly building that back up in a way where we're trying to make other structures stronger by working on strength and conditioning. Would you agree, Tausif?
Definitely. I often, you see that, as we talked about this, that's exercise-induced leg pain. Medial tibial stress syndrome predominantly is running activities, and these are when they actually have the symptoms a lot more. So I modify the activity, and if they are in the gym, they end up going onto a cross trainer, they end up going onto a bike. So they're still doing cardiovascular and general exercises, but they're just not having that similar sort of impact by running. I have got a young man who is actually aiming to go to RAF, and he's suffering with this at the moment, and we've changed his running plan, we've changed his running surface, and we're getting a good feedback at the moment. So it's not about it's not always about like stopping altogether. It's about like modifying the activity, and I think that's really important. When you see somebody as a clinician saying that, right, that's it, you can't do this at all. For me, that's not acceptable.
No, absolutely. I completely agree with you. So it's about finding a appropriate activity dependent upon what stage of the rehabilitation that they're at. Completely agree with you. Okay, so I'm not going to go into this in detail, but this is something that we would do to look at a rehabilitation program as a whole. Okay, and it just goes to show that we would be using different markers for strength, and if the patient's doing jumps, landing, we're looking at different like dynamic strength, and we're looking at different structures. And this is a rehab program in detail, but we can break this down into something very simple, which is what I do for everything. Mm-hmm. Everything is broken down into 6 stages of rehab, and then that global rehab program we focus on. And essentially, this is the same thing that we would do for tendinopathies or anything. Yeah, it's the same sort of thing. We would reduce pain, work on isometrics, improve strength, build functional strength, increase power, develop that stretch shortening cycle. And it's just that graded response that we're going to do. And most importantly, we get sport-specific drills, depending on the sport that they're playing, to get them to where we want to get them. So before I move up to the exercises, is there anything you want to say about your view on rehabilitation for medial tibial stress syndrome?
No, I think that's exactly the format that I would actually follow. I'd identify what sort of stage they are at, we'd identify what they can tolerate, and when does the pain starts to become a bit of a problem, and we form a baseline with that sort of knowledge, and from there we progress upwards.
Absolutely. So I'm going to go through a couple of exercises. Now, there is no right or wrong rehab program, because me and Tausif might give completely different exercises, but the aim of it, sorry, the aim of it is still to accomplish the same thing. So step-ups are highly effective. Now, some of the researchers said that you get the most amount of glute max activity, and it also gives you glute medius activity. So we're trying to strengthen some of the muscles around the hip here, because we know that if we can strengthen those muscles, we can absorb load during running, and that can lead to a reduction in the amount of stress that's being applied to your lower leg. Now, it's very important that when we do this, I haven't got a video of this, but it's very important when you do this in an upright manner. You're putting one foot onto a chair or any bench, and you're coming up and you're forcing your weight through the through the leg that's on the chair or the bench, and you're coming up in like a straight line. Often what I do is I get the patient to on their leg that they're like standing on, I get them to push off from their toes. I don't want them to push off from their heel. So we know that if they push off from their toes, they're going to activate more of the glute of the glute muscles. Yep. Is this something that you give to your patients, Tausif?
It is exactly something which I give to all my MTSS patients. I modify the height a little bit depending on what stage they are at to make it difficult or easy. You can add further loads by having weights in the hands or a backpack, or I don't think it would be safe to actually do it with the weights on the shoulder, free-flowing weights on the shoulder, unless you need to be able to use the equipment effectively. It's not safe to be stepping up with that. But yeah, that's what I do. I'd progress it. I'd progress with weights, height. I manipulate these things as to patient's requirement.
So what I haven't spoken about here, and you've completely right to bring it up, I haven't purposely mentioned the number of repetitions, the number of sets, and if you're going to add load like dumbbells or kettlebells, mainly because this is not prescriptive. It really depends on what we find in clinic and the general body makeup of that particular athlete. Some athletes won't be able to even do this, so they might be doing some lying exercises, like the bridge, or other exercises of that nature. But the repetitions and the load needs to become harder over time. Otherwise, if you're doing it and it's too easy, then we need to make it a bit harder for you. The next exercise, the SOLEUS squat. I've taken this image from our friend and colleague Tom Groom from one of his lectures. So I really like this.
I would just to actually tell you that when now I went to school in Pakistan, so I'm not sure whether this would be allowed here or not. But whenever we wouldn't behave, our teacher used to get us to kind of sit in that position as a punishment.
Yeah, that's what we used to get as well. When I used to go to mosque here, so it's very common. Maybe they all know these evil methods, but it did make our quad stronger, didn't it?
That's true, yeah.
Anyway, so you lean against a wall or a door, and you're in a slightly crouched position. So that's very important. And then you come up on your tiptoes and you come back down again. You need to push from your toes. So you're not putting much weight going through your your heels at all. Now, the lower you go down in the squat, the harder you're working your quads.
Yeah.
Sometimes you can work both muscles at the same time. So you can work your quads and your deeper muscles of your calf at the same time, which can be highly effective in treating medial tibial stress syndrome. Would you agree, Tausif?
Absolutely. This is one of my favorite exercise, and it's very common that even the gentleman that I was talking about, like the young man who wants to go to REF, he's a very fit guy. He's been training for a long period of time. He's the only thing which he didn't do was the running, but otherwise he's a very fit guy. But when I tested his SOLEUS, gosh, that was awful. And when we started talking about his pain, and I mentioned the word that right, we need to strengthen your calves up, and he started looking at me thinking that right, I lift this much on a regular basis, and you're telling me that I am weak. He's pretty like, he's very cut up, six packs and everything going on, and he took that kind of like offensively, that I'm saying to him that he's very weak. And I said, right, let me actually explain to you. Let's do the exercises. So when we did the squat exercises, he couldn't manage any more than 6 with his own body weight. And he just kept going off and then trying to do it again. And he goes, why can't I do it? And it's quite common that when we're working our calf muscles, we forget about our SOLEUS, don't we?
So what often happens is when you see people in gyms, they do like a standing calf raise using the machine, using the like Smith machine, but they don't do the seated calf raise, and they don't add load on. Is very, very important you build that muscle strength, because that particular muscle, it takes, I don't know, 5 or 6 times your body weight when you're running, and it absorbs a lot of shock. I think I spoke about it on a previous talk. It takes a lot of shock. So that muscle, we know from the research, and the glutes are the obvious things that we should try and make stronger. But yeah, I completely agree with you. Sometimes these big, powerful men and women who have a lot of strength may not have a strong SOLEUS muscle, which is something that we need to build up. So we were talking, I did speak about it before, and I've just put a slide here about the bent calf raise, and we've got dumbbells. And if you're doing this in a seated position, especially if you can take it into an eccentric load, which is what's happening in the slide, it can really help, because it helps to build that deeper calf muscle. And it's taught that it's key to the development. A weaker SOLEUS is taught to be a key to the development of a bone stress reaction injury. Now, do you normally give straight leg calf raises as well, with them standing upright?
Yeah, I tend to do both.
Yeah, you and me both. I tend to make them do more exercises seated SOLEUS, so I'll tend them to, and they tend to be harder, but we do want them to focus on the gastrocnemius as well, which is the 2 muscles on the top of on the back of your leg. Single leg SOLEUS bridge. Now this is when we start to get a bit more difficult, because this works on not just your SOLEUS, it also works on your hamstring. So the idea is to get into that position. You want to have the ball of your foot on a stepper, and you're literally coming up as a bridge. And it's focusing, it's working a lot of different things. It's not just working your SOLEUS, you're working your glutes, you're working your hamstrings. You get a lot of bang for your buck with this exercise. This might be later on during the rehab process that we might start doing a little bit of this. Would you agree, Tausif?
Yep, absolutely. I commonly use this one in more of an advanced stage as well. Yeah.
Now, global development. This is something that I want to speak to you about. Doing planks, box jumps, single leg drop squats. There's all sorts. Deadlift, which I think is awesome. Now, with your cricketer that you had, explain to us how you developed this global development of his body.
So he had, when he came to me, he actually had MRIs, he had everything, and it was clearly medial tibial stress syndrome, and he rested it for a little while. And the thing that he was finding it difficult through, that whenever he was going back into bowling, he would get the pain again. So it's no pain normally, and because he's from Pakistan, I don't think he had access to the kind of physiotherapy at that time, because he was let off by his national team that he was playing for because of his injury. So he got in touch with Aisha. Aisha referred him to me, and we just did that as a project without any charge. So what we looked at is that I looked at his running. So there was a bit of that crossover running, and especially, which was when he approached the last bit of his run-up. So he ran in fairly crossed over gait. But when he got to the last few steps of his bowling, he aggressively crossed over because he was trying to generate a lot of power to jump up and then bowl. And with the crossover sort of gait, the tibial bend, I felt, was one of the main contributing factor in his case, which was exacerbating the symptoms. So I started looking at, he was fairly aware of gym, and he was strong enough in general. So we started to get him to do general strengthening, which included deadlift, which included his core development, which included his glutes, quads, hamstrings. So we looked at the separate plan for that in the gym. And then we did a separate sort of plan for his lower leg strengthening as well. And it was very gradual sort of process. And he was really pissed off with me at one stage that I wasn't allowing him to go and run up and bowl properly. So, and in terms of the running as well, I said that you can't have a ball in your hand, and all I want you to just run. And as you probably know, that there is a mark-up line around the ground, and we use that line as to open up his gait so that he doesn't have that crossover. And I said that all I want you to do, I don't want you to be basically running with your feet on one side, but all I want you to do is just not cross that line. And I think that was one of the running retraining we did, kept him sane. In terms of the strengthening that we've actually done, got him to a stage when he could come up, run up, and then bowl. And luckily, he's actually playing for the national side again.
Brilliant. So what you just did there, Tausif, was a holistic rehabilitation program that involved lower leg strengthening. You included global development, including getting his core tightened, working on the plank, deadlift. You did gait retraining to make his running wider, and I know you gave him some orthotics as well to give him some absorbency. This is when you go to a sports podiatrist and he can do all of this for you, goes to show the benefit of visiting a sports podiatrist, because we are going to look at the entire body and not just the area of discomfort. But that's brilliant. That's a brilliant example of what to do. Gait retraining in general, I mean, I'm not gonna. This gait retraining is something that we're gonna have a whole talk on. There is some evidence that regarding changing the stride width makes a big difference to these type of injuries. It is quite difficult to get them to do it and not go too much. Then they go too much. But I find that just changing the cadence, or maybe changing the body position during the run-up, can make a big difference to the landing position when they're going to bowl. So these are all things that we've taken into consideration.
We had to, while we were building the strength which is required for him to kind of jump up and bowl it with his natural action, we tried to modify his bowling action as well. I didn't want to mess around with his bowling action too much, And same thing with my runners as well. When I'm rehabilitating and using gait retraining, I'm kind of using it partly for rehabilitation purposes, and so that patients can keep on running, and but they're not putting the same level of stresses that they would do running normally. But it's not something I haven't really found, unless you correct me here, I haven't really found enough credible evidence to say that, right, I need you to run like this forever. For me, it is up till like once I've got them strong enough, once they're injury free, once they're strong enough to be able to do certain activities, I want them to carry on.
I agree and disagree. I am a bit more open-minded about this in certain ways. So we ultimately know that overstriding can lead to a vast variety of different conditions, but not every overstrider will get foot and leg problems, or just like a leg problem. But one of the things I do focus on is cadence in runners. So the amount of steps they take per minute, because we know that can affect overstriding. But that is a different talk for a different day. Plyometrics. Plyometrics is essentially, we're talking about doing exercises which involve jumping, and that could be 2 legs, 1 leg. We may change that from a vertical to a split squat to a jump, power skips, lateral jumps. I think it's important that we start to introduce them to plyometrics at the latter stages of the rehab, because we need to increase the intensity.
Well, James Dunn, he talks about bulletproof, so doing the exercises and building the strength to be bulletproof so that you can do any activity in a way. So when you're doing a rehab, it's we talked about in our previous talks as well, that they have to be specific to the goals that we're trying to actually achieve. So if because this is associated with exercise-induced injuries, so you want them to be ready for the exercise or the sport that they want to do, don't you? And you can't do it without plyometrics.
It's also highly dependent upon, as we've said before, where do we want to get them to? So we start this off with the end goal in mind. If the end goal in mind is they are an endurance athlete, then we have to think about it a bit differently. If their end goal in mind is they are a footballer, the kind of plyometric drills that we're doing will be slightly different to these. These will be pitch-based drills, and it may be with a ball, but it will be different kinds of drills, maybe different activities. But we do want to get that kind of cycle where they can jump and land properly, because at one stage of your running cycle, you're going to be putting all your weight going through one leg. So we want to make sure that you are strong in that regard. Anything you want to add to this?
No, that's good.
I think we're nearly finished. Treatment adjuncts. This is very interesting. Very interesting. So we know from a study that was carried out in 2009, orthotics can be effective in reducing shock. They did a systematic literature review in 2013, where they compared loads of different treatments for medial tibial stress syndrome, and they found that shockwave appears to have some promise. Now, I've done shockwave on patients with this. It is bloody painful. Oh, let me just switch this phone off, sorry. Okay. Patients that want an appointment and I'm not open, in fact, we might open next week. So they found that shockwave can be highly effective for patients that have medial tibial stress syndrome. They need multiple sessions. I know there are some armies, as I mentioned it before, army physios that are doing it. Would you add anything to this?
No, I think it can. We talked about shockwave in a little bit more detail last time as well, that it aids and it speeds up the healing process. So yeah, it can be quite an effective tool for MTSS.
One of the interesting things that they did in the army in Cyprus is, instead of the practitioner holding the shockwave machine, they got the soldier to do it, and they got the other soldiers to watch. And because he had his mates watching him, he never showed any pain. And I thought that was a very clever strategy. And I thought that was fascinating, just what they did. And they compared it to like other soldiers that they did it to. And what they found was that the soldier that did it to himself got better quickly, right? And that was very interesting. Very, very. Obviously, they know where to put the actual shockwave machine. And also, because they've got somebody else watching them, they ain't going to flinch and move because they don't want to show pain. I thought that was brilliant, absolutely brilliant. Orthotics, we generally just give something that's just going to absorb shock, don't we?
Yeah, that's like I said, I've come across a few papers which suggest that navicular drop and drift can be one of the risk factors and can contribute toward the discomfort of it. So I like to give shock absorbent and just a bit of support, and I think that assists. It's a short-term thing until we're strong enough. But I like to use it the patient, and I get a fairly decent success rate.
Brilliant. So that's me and Tausif saying thank you. First of all, I want to highlight, if you haven't already learned in the last 50 minutes, not all leg pain is shin splints. Don't use the word shin splints, otherwise I will come and find you. Visit a sports podiatrist like Tausif or myself for a thorough examination and history taking. We see a lot of exercise-induced leg pain, and it's worth visiting somebody like myself or Tausif, because we may be able to consider all the other possible things that we can do. And most importantly, we can give you a rehab program that's not off Google, but based upon what we find in clinic, based on you. Any final thoughts, Tausif?
Well, just to actually further comment on that rehab plan, that I find that some of these runners who have basically been on the forums, on the Dr. Google, and they're doing the similar sort of exercises when they come to see you, but they're not getting anywhere. And I think the importance here is that you look at things very holistically, and you're not just focusing on the painful area. You look at it globally toward the whole body. At the same time, knowing where you are, as you know that if you're building strength, the repetition needed is completely different. If you're building endurance, the repetition needed is completely different. Being able to do 10 step-ups doesn't mean that you can actually do plyometrics or jump-ups. And being able to do jumps up doesn't mean that you can run a 10K. So everything has a very gradual approach, but identifying where you are and building it from there can speed up the process. Otherwise, if somebody's starting too low, they're not going to get any improvement because they're training too low. If somebody starts too high, then the risk of them further injuring themselves is more. So finding the right balance is the key, and that's where I think you and me come in, don't we?
We do. Also, I completely agree with everything you said. Also, if they come to us and they say they have a specific event that they want to aim to get fit by, then we have a target, then everything gets focused around the end goal. They know that they are going, if it's like, I just want to run on the weekends, then that's an open goal. Then we've got more time. If it's a specific goal, then we are going to tailor it towards that goal. Just like you said, the different stages of rehabilitation, the like neuromuscular, the strength and conditioning, the strength and power, and then power, and then sport specific is very important. Let me stop sharing the screen. Tausif, so you are the next talk you're doing, aren't you?
I am.
Yeah. What are you doing?
We're doing tib post dysfunction, aren't we?
Yes, we are. And then I think I'm going to have to take a couple of weeks off because I have got exams that I need to prepare for, which is interesting. So, but yes, but we are going to come back because we've got so much more to talk about, don't we, Tausif?
Yep.
If you have any questions regarding any of the topics that we have brought up, either go to Tausif's Facebook page or my Facebook page, or find him or me. Either of us will be able to help you. If you just want any advice regarding your medial tibial stress syndrome condition that you have been getting, just like hook us up, find us. We will talk to you and we'll be able to advise you. And even if you're not in the UK, if you just need some advice, we are very giving and open to advice, and Tausif especially. So bombard his inbox, right? Everybody, send him 100 emails a day. He will always say yes to you, and we will help you.
I know how to forward emails of it.
Any final thoughts?
No, I think that sums up quite nicely, and yeah, thank you very much for listening, and we'll be back in a couple of days' time again.
We will be back just like Arnie. Thank you.
Yeah.